Good morning, good afternoon, good evening, friends, depending upon from which part of the world you are joining us from. So this is Dr. Vijay Agarwal, President CAHO, welcoming you to this very, very important international webinar series that we do with ISQua every first Tuesday of the month. And this Tuesday, for this particular webinar, we have a very important topic of developing culture of safety through the teamwork. And to do this, Ms. King from the New South Wales in Australia, and she will be introduced to you by our moderator, Dr. Palin Khundongbam. Dr. Palin is a very well-known name, at least in the CAHO circles. He is a surgeon and a plastic surgeon, and coming from Northeast, I would say, one of the most humble persons I have known, who has, to his credit, records in the Guinness Record Book, etc. People would not know that he features for having removed the biggest tumor from the body. Almost for the 40% weight of the body was a tumor that was removed, and he had stitched, I think, 7 or 8 fingers. I don't know how many. So he has a huge amount of, I would say, domain knowledge and in terms of credit to his own professional work. But besides that, he has developed a marvelous institution in the form of the Shija Institute, of which he is the managing director. His daughter also worked very closely with CAHO, and we have very close association with Dr. Palin. He is also going to be a co-chair of our program, which is coming in CAHO-Con at Calcutta in April 2024, 5th, 6th, and 7th. So, Dr. Palin, we are truly indebted that you are here today and you are going to moderate this session. Your biodata, sir, is so long that if I go to read that, we will not have time for Ms. King to speak. So that's why I'm truncating it, and I'll be forwarding your all information to everybody. So over to you, Dr. Palin.
Thank you, sir, for the liberal appreciation, and good evening to all, and morning to some. We are deeply honored to have the speaker, Bernadette King. I would like to say something about her. She is the principal lead system safety culture. He's the lead principal lead system safety culture at the Clinical Excellence Commission, NSW, Australia. Bernadette is an experienced, organized, motivated project and change manager with a proven track record in leading program development, successful large-scale implementation. Our current role includes development, implementation, and the evaluation of statewide quality and safety improvement priorities with an emphasis on team effectiveness, communication, and safety culture. Bernadette is a registered nurse and gained most of her clinical experience in a variety of acute surgical settings. She completed her Master of Nursing in Professional Studies Management major in 2002 and completed her graduate diploma in Human Factor and Safety Management System in 2013. Bernadette has worked in the quality and safety field for the last 25 years. We are deeply honored. And ma'am, the floor is to you, please.
So thank you very much, Dr. Palin, for that lovely introduction, and good evening, everyone. Yes, I'm Bernadette King. I'm the Principal Lead for System Safety Culture at the Clinical Excellence Commission in New South Wales. And it is my absolute pleasure to be with you this evening to talk about safety culture, the role of the team, and how it's key to the development and transformation of our culture in our healthcare organisations. So what I thought I would do is just give you a bit of an overview of the issues that affect safety culture, and then tell you about some of the resources and tools that our team have developed and that we use when working with teams to build the culture of safety. I absolutely acknowledge that I probably won't be telling you anything new or something that you don't already know. But what I hope I can do is provide a different context and a different perspective around safety culture and its importance to how we work and care for our staff and our patients. So as you know, I'm in Sydney, Australia, and the Australian First Nations people of Australia are the oldest living civilization and culture. And part of what we do when we do any form of presentation, we recognise their ongoing connections to the lands and waters. And tonight I'm on Guringai and Darug land in New South Wales. And also the recognition of living experience. Our consumers and partners' contribution is absolutely vital to the work of continuously improving safety and quality in our healthcare system. Now, the addition of this slide into our presentations for the Clinical Excellence Commission was led by our Partnering with People lead, and it's new for the CEC, but it's been really enthusiastically being taken up by the whole of the organisation. So just that small example of culture change. Sometimes it doesn't have to be the biggest or brightest or newest thing that you implement. It could just be something as simple as this. And it doesn't have to come from the top. We are all leaders in change and culture transformation. So you may not know much about New South Wales. I'll just very quickly tell you about how we work in the public health system in New South Wales. So we are made up of 15 local health districts and 2 specialty health networks and the New South Wales Ambulance Service. And we are the biggest public health system in Australia. And we have about 228 public hospitals and just on 130,000 staff who make up the health workforce. The Clinical Excellence Commission is one of the New South Wales Health Pillar agencies, and we report to the Ministry of Health. And we're the lead agency supporting safety and quality improvement capability in New South Wales. So we have programs around sepsis, the deteriorating patient, medication safety, end of life. And so those are done as part of an improvement process. But over the last couple of years, so the last 3 years, we were the lead agency for New South Wales during the pandemic. And so while our focus was very much on infection prevention and control, it also came as that catalyst for how we deliver our programs, but more importantly, how we care for our staff, not only in times of high stress and crisis. So just a little bit about me. I've worked in healthcare in Australia and overseas for over 40 years. I'm a registered nurse and I trained in the old apprentice system. So I left school in the December one year, the next year started as a bright-eyed 18-year-old in the January. And after 6 weeks in the classroom, I walked into the ward and my life changed. I love health and I love working as a nurse and I love working in teams. And I think my training was that instrumental in the way that I've worked throughout my career, where I've left some of maybe the better jobs, well-equipped jobs, but the culture was bad, but stayed in jobs where it was harder work, but the culture was so good, it was safe. People were able to speak up, it was supportive, it was patient-centered, and we had fun. I'm coming to the end of my career. I am retiring at the end of this year, and I am very lucky that I'm working in a job that I absolutely love and am passionate about. And I'm also privileged to work with a fantastic team who really work to integrate that psychological safety, culture, well-being, and importantly, the fun into our work and the work that we do working with teams. So this is the team that I work with, and our main focus and what we work with is really we partner with clinicians, mainly at that point of care, so that clinical unit level at that ward base, to create those conditions that provide a safe environment that enables improved teamwork and communication, with that focus on building a safety culture and improving that experience of staff. So all members of the teams have areas of responsibility, areas of expertise, and they're leaders at a statewide level in their programs. But each of them can support each other's work, and we work towards that common vision around teams and improving safety culture. So the theory that we use in the way we work is the 3 waves of innovation. And you may have seen this elsewhere, but basically it's that first wave is really focused on those technical advances. So surgical techniques, novel medical therapies, focused training, etc. The second wave was around standardization. So checklists, audit and reporting, and quality assurance. And these advances have really reduced mortality and morbidity in health, but they are at risk of plateauing. So the third wave goes beyond the technical and structural innovations and focuses on embracing the variations that affect patient safety, such as the way individuals, that is teams, interact with one another, so that context and where they work. And so really can lead towards that highly reliable performance. Innovation and standardization are still really important. The systems and processes and policies and models of care and evidence-based work that we do is the foundation of how we care for our patients. But they can't do that behaviour change and culture change by themselves. So what do we mean by safety culture? So within the literature, and when you may have seen, there's all different definitions around safety culture, especially within industry as nuclear and transport. But the definition I like and I've taken from the literature is that a safety culture is an organisational culture that places a high level of importance on safety beliefs, values and attitudes, and that these are shared by most of the people within the workplace. So safety culture is basic to achieving that safe, quality staff and patient family care experience. So why do we focus on teams and teamwork when we talk about safety culture? As we know, teams are the foundation of how we do work in healthcare. Most of our model of care are delivered as part of a team. And the benefits are not limited to the impact on our patients, which does include things like that harm minimisation and improved safety, but also on staff experience, such as reduction of stress and improved job satisfaction. So high reliability teams are the building blocks of high reliability organisations, and they value a culture of safety and work mindfully to achieve it. This is an old saying, culture eats strategy for breakfast, which I'm sure you must have all heard when talking with teams and change. And basically what this quote means is that no matter how strong your strategic plan is or your change plan is, its efficacy will be held back by the members of the team if they just don't share that culture, or they don't share the aims that you're trying to achieve. So, of course, when it comes down to it, it's the people implementing the plan are the ones that will make a difference. And I'm sure you can all maybe think of a time or an example, or you've heard an example where this happened. But I always think of this one project that I was leading that really kind of brought it home and really influenced the way I work now with it. We're looking at teamwork. So before I got this position, I was a statewide lead for an implementation of a patient care thing around end of life. So it was just a small intervention around having discussions with patients around end of life. And we were going to pilot this intervention. And we had this team who put their hand up and said, look, we're really interested. They had senior executive involvement. They had the head of department totally supported them. They even was given a project officer who could support them during the pilot time. So, of course, I thought, well, this is going to be easy. I'm not going to have to do anything here. But, of course, as you know, that's not how it turned out. I would check in with the project officer and she'd, oh, look, no, not a problem. I'm just still doing education with nurses. Next time, oh, look, I'm just still doing education with medical staff. Next time, I'm still doing education with allied health staff. And I suppose the red flag for me was, why is she not doing multidisciplinary team education? And so when we found out about it, it was basically she was struggling to get the team to work together because the nursing staff thought that this intervention would help them tell the doctors what to do. And of course, the doctors didn't want to be told what to do. And the allied health said, you know, we're getting all this education, but we don't know what we have to do in this intervention. And so and these were good people. They came to work every day to do the best for their patients. But what we hadn't appreciated was how the team worked, how they communicated. Did they think that this was something worthwhile for them as a team to work on? So, you know, everyone says, oh, the program failed. Well, no, not so much the program didn't fail. It was a good program. Is we had failed the team because we hadn't put that into consideration before we put a change process in place. So again, very, very big lesson learned there. But another block to developing safety culture is most probably what you might have heard, look, that's always the way we've done it here. Or else, look, that's just how he is. Look, that's how she is, or that's how they are. And of course, no one will feel safe in that environment. They can't speak up. And it's where those bad behaviours are tolerated. So that poor culture, no matter what you do, will not improve within that team. So positive safety culture exists where there is an environment of trust and staff feel safe to speak up. So that's that psychological safety is in the team or the organisation. And Amy Edmondson's definition around that shared belief to take interpersonal risks, I think is just such a great definition, and we use it for all our work. And I know she's got quite a following around the world. She's a very smart lady. And one of the things with that interpersonal risk is that teams are more effective when staff feel comfortable to admit that they make a mistake or that they don't know how to perform a task, or this is the first time I've looked after a patient who's had that procedure or is having that medication, and being able to think that I can safely say that and that people will support me. That they can share knowledge and experience and learn from knowledge and experience of others. So it's done in a really collegial, safe way around sharing experience. And they feel they have space to question, but also to innovate, which is really important when we're talking about teams, when we're talking about safety culture. It does take time and it does take consistency, and it takes trust to build that psychological safety. And it's not, and it can be quickly dissolved if staff don't feel safe or they feel that if they put their hand up, they will be ridiculed. And I was speaking to someone who works with teams quite a lot, and he was kind of saying to me that sometimes he feels that he's one eye roll away from someone and they lose everything they build. So again, it's that really simple, it's a really hard thing to build, but it's a simple thing to lose. So how do we build that psychological safety? So the enablers of psychological safety are needed at all levels of the organisation. So from the individual, the team, to be the voice for safety, and from the organisational level to build those conditions for the voice for safety. So we all have that role in building the safety culture. And a question that comes up is, where should you start when you're looking to either build or transform safety culture? And realistically, you need to start at the top. You need to have that executive engagement and support and role modelling when building a safety culture. You can certainly work with teams and individuals at the same time, but it is that leadership that is critical to build the conditions for that voice for safety. So those are some of the enablers. So what are some of those barriers or things that get in the way of building that psychological safety and safety culture? So power dynamics are always present to some degree in our health organisations, just by the virtue of the hierarchical nature of the roles and responsibilities in health. And sometimes those are very appropriate. But sometimes you do need to have that command and control, especially say through a trauma call or an emergency response. But even in those situations, you still need the team around that lead to keep things safe and achieve the outcomes. So if there's no psychological safety for the team to contribute or speak up, power dynamics can be a really destructive force for a team and culture and for our patients. There's a lot of work being done around incivility and its effects on teams and culture. And especially there's a lot of evidence within the literature that's come out over the last 5 to 10 years. And Dr. Chris Turner from the NHS, who is an ED physician, has founded Civility Saved Lives. And he has a great TED talk, which I would recommend. And it's when rudeness in teams turn deadly, just telling a story around what happens to a patient when the team is rude to each other. And of course, within the literature, what they've found is that when someone has been subject to rudeness, 80% lose time worrying about the incident and 38% reduce their quality of work. So a really big effect to the team and to that person individually. In relation to the impact of those who observe the rudeness and how it spreads through a team, it's a 20% decrease in performance by those who observe it and a 50% reduction in their willingness to help others. And those others are usually other staff, their colleagues, or patients. And there's also those many other impacts, especially to staff wellbeing. So there's a 78% reduce their commitment to the work, 63% lose time avoiding the offender. So that's exhausting. And a lot of times they end up leaving the organisation. 38% reduced the quality of their work, and 25% took it out on others, including patients. Now, unfortunately, I'm sure we've all seen or been subject to rudeness and remember how it felt. I certainly have. And what they're finding is with the literature, and I suppose we intrinsically know if we've experienced it, is incivility robs teams of their potential, and you cannot feel safe in that environment. So when a person's well-being is negatively impacted by any way, it can manifest in its extreme as burnout, emotional exhaustion, depression, and anxiety. And patient and staff safety are reliant on that individual accountability and effective teamwork, which in turn depends on multiple factors, including staff well-being. So what has well-being got to do with safety culture? Well, how a team works plays an important part of well-being, and that well-being supports the building and transforming a safety culture. The well-being of healthcare workers is a predictor of safe, effective healthcare delivery. Previously considered a luxury that we just didn't have time for, well-being, compassion, and kindness are now recognised to be essential for safe quality care. And there's a science around it. There's a lot of literature and evidence coming out in more and more around the effect of compassion and kindness for improved outcomes for patients. And as previously noted, I talked about where psychological safety for teams is built, is usually spoken about when we're speaking up around concerns for our patients or those risks and building that safety culture. But teams also need that psychological safety for well-being. So to be able to speak up about how they're feeling, how things are affecting them at home and bringing it into work. We all work as part of our life, and part of our life, sometimes we have a flat battery, so we're running late for work. We've been up all night with a sick relative or a sick child, or we were on the late shift last night, back for an early shift, and we couldn't get to sleep, so feeling a bit tired. All of that influences that. So team members having that psychological safety enables other team members to be aware and support. And again, so within that environment, staff wellbeing and patient safety is enhanced. So I've really just kind of covered some of the various issues around safety culture and how developing or transforming a safety culture is influenced by many factors. And I hope I've been able to demonstrate that the team is one of those key factors in building safety culture. But making it happen or operationalizing the components of teamwork, those habits, behaviors of how we do things around here, these are intentional and take work. And this is what the focus of our team's work is in New South Wales Health. So what I thought I'd do is share some of the tools and resources that we've developed and we use with working with teams. Of course, these aren't perfect. They don't fit every situation. And there's a lot of resources and tools around culture, but this is what we use. And all of our resources and tools are available on our website. So I spoke about the various factors that influence the safety culture and that everyone has a role in enabling it through attitudes, behaviours and actions. But really, what are those elements that make up a safety culture? And when we were looking at this and trying to say what our definition of safety culture was, we thought we did a bit of a literature review, and the framework really came out of based on James Reason's 5 elements of safety culture, with the addition of Sydney Decker's restorative culture and the element high trust, which really came out within the literature. And the framework is underpinned by compassionate leadership. So the aim of the framework is really to promote a shared mental model of the interconnected components of safety culture and just highlight that importance of compassionate leadership as an enabler. When we put compassionate leadership in the framework, we did get quite a bit of pushback. People saying it's about softness and everything else like that, but it isn't. Compassionate leadership isn't about soft and fluffy. And well, why we chose it was again from the literature, but there was also a lot of work done by Professor Michael West and his team at the King's Fund in the UK. And they've done a lot of work around this, and they've kind of looked at it within how leaders model a commitment to high quality and compassionate care. It can impact everything from clinical effectiveness, patient safety and staff health, well-being and engagement. And so compassionate leadership is a combination of empathy and good leadership skills. And it's not about taking on people's problems and trying to find a solution for them, but it's enabling people's development so they find their own solution. And compassionate leadership behaviours enable a safety culture. But it's just not in health when we're talking about compassionate leadership. As I said, within the literature, the role of compassionate leadership is also recognised in the business world. So they look at Harvard Business Review, Forbes magazine, as being one of those key to success and providing those benefits to an organisation's success. It's also seen in the sporting world. Earlier this year, we had the Women's World Cup and the Lionesses from England, they got into the final. And one of the things that came up within the press was around how their coach's compassion was noted as producing a better performance. So if you're using the framework or any framework, how do you know you're achieving improvement? Or how do you even demonstrate that you're progressing or transforming your safety culture? The Hudson model provides that a framework which plots the development and maturity of an organisation or team safety culture. So each level has distinct characteristics, so progression from the previous level. So the range runs from the pathological, where we're just not going to try and not get caught, through to the reactive, to the calculative, to the proactive, and then the final stage is the generative. So this is business as usual. This is the high reliability. And within this model, it's usually when you're at the calculative stage is when you hit that tipping point for psychological safety. Communication is one of the leading causes of adverse outcomes for patients, but is also one of the major causes that affects staff experience at work. And this is an area that we are constantly called in to work with teams as they are concerned around communication within the team. And so, and that could have come from an incident, or sometimes the new manager has come in and they think that they can improve on some of the communications. And so the safety fundamentals are activities which change those behaviours that impact safe quality care. And they're consistent with the research on the 3 ways of innovation, which I spoke about earlier. And the fundamentals are evidence-based, standardised processes that can support improved communication, teamwork, and safety culture in pretty well any setting. Many of the safety fundamentals are already well known and being applied in practice. And so our reason for putting them under this umbrella and calling them safety fundamentals was really, our aim was to raise that wider awareness of them and then further embed them by promoting and supporting their use. Lots of the features of the safety fundamentals is they're behaviour focused. They're evidence-based, which is really important when we're working with clinicians. There's got to be an evidence base for why they need to change and what they're going to implement. And they're sustainable. And they're sustainable mainly because you don't need any extra staffing, you don't need extra equipment, and you don't need any extra infrastructure to implement these fundamentals. So each of the fundamentals can be adapted to suit unique needs of any clinical unit, as long as the key principles are observed. So we have safety fundamentals for teams. So those are safety huddles, leadership walkarounds, intentional rounding, and safety fundamentals for patient-centered communication. So things like teach back, hello, my name is, what matters to you. And as I say, as I said before, you don't need extra staff or anything else like that to implement it, because tomorrow you could all start introducing yourself on new interactions. Hello, my name is. Simple. That's the way we're going to do things from tomorrow. You can put safety huddles in next week, because you're going to do a bit of preparation of what time is the best time for the team, what is the focus of the huddle we want to be, and so then you can implement it. And the leadership walkarounds take a little bit longer because you've got to get in executive diaries, etc. So as again, they're about those communications changes and how you do things around here and building that teamwork using these particular tools. We've developed a lot of resources and guidance for the fundamentals. And again, they can be anyone can take them and use them and localize them for how they do their work within their local area. And again, it's the simple things around, we call them safety huddles, but some people call them safety briefs or pauses or scrums. And we're very happy for people to use that, because that is what they're happy doing. Another tool we use when we're working with teams is a safety culture survey. By doing the survey, teams can appreciate safety culture is something that needs to be invested in, nurtured and cultivated, and they have to work at it. And it really enables teams to be able to see where they are and decide where they want to be and how they want to get there. So we use the Safety Attitudes Questionnaire from the University of Texas, and this measures attitudes to safety and the workplace among healthcare staff. It's a validated tool, extensive use in multiple healthcare settings, both nationally and internationally, and in hospital in the community setting. And it's divided into 6 domains, with each, 4 to 8 questions, but looking at things like teamwork, safety climate, and stress recognition. And look, there are certainly, we use this one because it works for us, so it's not about endorsing it. There are other validated survey tools for use in health, which are excellent, and they're just as good. Because any survey that you use to do this can be a blunt instrument. It's how you use the survey, how it is done, and it's done with an improvement lens that the team will gain value from the process, because that data needs to be used for them to improve. So again, we wrap it in a process around we're not doing a culture survey, tick box exercise. We put it within a process around that preparation. So that's around communication, engagement. The survey is done. That's just one part of it. And then it's the feedback and reporting. It's that facilitated discussion, getting people's feedback, and then that action planning and people taking responsibility for what they want to do from the survey. Another thing that Clinical Excellence has done in response to issues around wellbeing, especially after COVID, around that stress that came from teams, working in high stress situation, we developed a suite of tools around to support teams undertaking reflective practice. So reflective practice is a process of thinking clearly, honestly, deeply, and critical about any aspect of our professional practice. And it's considered good practice and is foundational to processing the challenges of the really high stress and high risk associated with healthcare work. And really what it can do is within a team, it can strengthen how we work around patient safety and quality. And it enables us also to identify those opportunities for learning and improvement. And importantly, enables us to see the interplay of safety culture and strengthen teamwork. So all of those interventions can be done by clinical teams of and by themselves. They don't need us to come and do it for them or do it to them. But what we do is work with them. So if someone's interested in, some of the safety fundamentals, they want to implement huddles or something like that, we'll go into a site visit, speak to the staff, do a presentation, work with them around setting it up. And then we will kind of back off coaching a local lead, so it builds up that capability on site, and we just act as that sounding board and coach, and really just walk away and lead them to do it. But sometimes we're asked after maybe a major incident or where people are trying different things and no change is happening, where they really want to do a formalized program around building their teamwork and building a safety culture. And we use the Team Stripes framework to bring all of those things that I've just spoken about together. And Team Stripes is based on human-centered design and enables us to take that step back to appreciate the context of that clinical unit, acknowledging that each has its own identity and culture. And what we do is mainly we start with a discovery where we look at all the data that they want to share with us. And that's usually the top 3 incidents over the last 6 months. We look at patient experience data. We look at their compliments. We look at their complaints. And we do the safety culture survey. But also as part of that discovery, we'll come on site, we'll do a couple of presentations, we'll meet the staff, we'll do some observations. So we'll either do observation of them doing a handover, or we'll just sit in the corner and observe how people communicate with each other. And we'll just have informal talks with staff. And usually we try and make sure that when we're speaking to staff, instead of going to them saying, what doesn't work, or why are you unhappy, or anything else like that, the question that we ask staff is, what is it that you love coming to work about? What really engages you with your team, and what is it that gets you to come to work every day? And all of that information we put into a report for the team, and then we do some facilitated feedback sessions. And then those are focused around, okay, this is what you look like now. What to you would really good look like? And they've got to decide what that is and what they want to do. And then the question is, okay, what do you want to do? What do you want to focus on to get there? And again, it's about them identifying what improvement project or areas they want to work on, and they will then lead it. And again, our role is around coaching and making sure that they have the tools and resources that they need, that they can do it. But they're very much around leading that work and doing it for themselves. So does it work? It's a really good question. I'm sure you're sitting there thinking, sounds very nice, but does it work? And look, it takes a long time, but it is worth it. It does work. We've worked with quite a few teams over the last couple of years, so I just thought I'd share with you a couple of the success stories that we've had. So we were contacted by a small local hospital to support their staff in identifying some improvements after they had done a self-assessment. So we did the diagnostic. So we did the culture survey, we looked at their data and everything else like that, and went and did some site visits and observations. And then we had the facilitated discussion. And, you know, with that question, what do you need to do to change the results to get where you want to be? And from that discussion, there were 3 priority areas that they were brought up, and it was around communication and staffing and food services and quality. So with communication, they didn't do any huddles. They didn't do any form of, you know, sharing information around the whole of the organisation or the facility. So they started daily safety huddles. And this is a photo of them doing, they sent us. And if you see the lady in the orange shirt, she's the gardener. And so what they did, because they had some aged care patients in the facility and they would go outside sometimes, she would either find out things and let the nurses know, or else the nurses would let her know to keep an eye out. So again, very much around that team, building that culture of team. And staffing again was around concerns about fatigue and reliance on locums. So they put in a business case to get some new graduates from allied health as well as nursing to come and do some time in their organisation. And food services, I have to say, this is one of the most surprising things that came up in any discussion we've had with teams. But it was really interesting that they brought up the fact that this is blended food and this is how the patients were given it. And it had all the, you know, the protein and carbohydrates and vitamins that they needed, but it looks terrible. And so it was around, of course, we eat with our eyes, and, you know, the patients didn't want to eat it. Family were coming in and they didn't want to feed it to their relatives, and the staff were kind of a bit embarrassed around feeding this to patients. And it seemed to be an issue that no one had ever brought up before until we had this discussion. Anyhow, the catering people were there in the discussion. They took notice of it. So they went out and bought a book, and they went and bought some molds. And what they did is then still blended food, but they made it much more attractive. So they used the molds. So the blended food was presented as its source, you know, carrots and broccoli and potato, etc. like that. So again, much nicer to look at and see as you eat. And convenient. So they got some finger foods, some like little party pies or little mini quiches. So for those patients with cognitive issues, so that they could handle the food, they weren't struggling with knife and forks and trying to get it to the mouth. It was much easier for them to eat. So again, something little that has a big impact on the culture and how teams work. And this is a rural outreach unit that we work with, and they asked around Team Stripes to help them as they had concerns with the approach to care, which they didn't feel was multidisciplinary in nature. And they identified as directly impacting the patients, particularly at transitions of care. So we did a discovery, site visits, tours, observations, they did the safety culture survey, so all that sort of thing. And again, facilitated discussion. And so they agreed that they would design and test a location-specific tiered communication process. And so basically they did that, and then we provided weekly coaching and then ad hoc. And then we caught up with the lead a couple of months later, and you know, they were saying that's really been successful, but what they found the most helpful was the fact is that they had to take the time to just really stop and look at how the team worked, how they communicated. And since then they made the change around a multidisciplinary team that they've made others because of having taken that time to look at how they work and what's going on. So safety and quality and patient outcomes, as well as our staff experience of work, are really directly impacted by culture and behaviours. Donald Berwick, this quote, he's a quality and safety leader, which I'm sure you've all heard of, from the Institute of Healthcare Improvement in the US for over 20 years or so. And he brought this out a year or so again after COVID, and talking about without a physically and psychologically safe and healthy workforce, excellent healthcare is not possible. And so we believe we work towards that aim of we can make a change and we can make a difference to our staff experience of work and our patients' experience of care through building our teams and transforming our safety cultures, but also acknowledging that it takes time and effort, but really it is a worthwhile investment of time. So thank you very much for listening and giving me the opportunity to speak to you this evening.
Thank you, Bernadette. Wonderful, wonderful this talk and giving a lot of importance to the psychological safety. We have another 12 minutes, and I would like to request the participant, if there are questions, please ask.
Dr. Palin, I think it has been a wonderful, wonderful session, as you
Yes,
said.
exactly.
I think a very important takeaway message for everybody is that this whole concept of working on the psychological well-being as well as on the teamwork is extremely important. And you have to
Yes.
work in the local culture and context. The
Exactly.
exact examples may or may not be of a particular this thing, but I am saying that you need to be sensitized, and this is at the heart of every problem today, and that is to build the team culture. Unless you develop this particular aspect of the teamwork, the problems or the medical errors are going to continue. So I think at CAHO, we should be looking at now many more hospitals to come forward with what kind of strategies they have evolved to develop the team culture and how has it helped them. So I think we will probably work on that very specifically. But excellent feedback, excellent presentation, and your initial slide which showed the 3 waves of how the patient safety is kind of now being led not merely by the technology innovations and the standardized processing, but more by the coordination, more by teamwork, is extremely, extremely useful. So any questions? We have Gracie Madam, any?
No, sir, it was really an excellent session. That only I was thinking like that is we practice in our day-to-day life. I think there is nothing except the patient will be safe in our hands.
Yeah.
Thank you so much. Thank you so much.
Thank you.
And Dr. Palin, as you can see, a lot of our monthly quality meetings are now taking place around these webinars. So I congratulate all hospitals, who have started this. On every first Tuesday, we are having the quality meeting, which is centered around this particular webinar. So nice.
Yes. Even today, some of our hospitals in Manipur have started participating. I have given the link, and they are participating right now.
Great.
It's a good change, and for the first time in Manipur, we are able to attend this. And you have told me before also, but this time it is the first time that we are joining the webinar, and wonderful and good standard. And we realize that our own culture and our own psychological safety, and we have to go. I think in the same culture and develop this change.
Vijay sir, there are questions in the Q&A. How can leadership be influenced to adopt safety culture in the facility?
Yeah, I think it's a really good question, and it's I think we all work on. As I said before, we need that leadership. The leaders have got to model that this is important to them, and as when we talk about psychological safety, and when I was talking about incivility, there is a cost, a money cost for bad culture. And sometimes you have to talk about the bottom line. And all chief executives and all managers have to look at their bottom line. And it's sometimes maybe that influence around with, there's money, but also it's about staff well-being. It's around, I'm sure you must probably find it there, but more and more coming out in the literature around that moral injury that we've caused to our staff over the last couple of years. And that has a cost, professionally, personally, and a bottom line cost. So that's a difficult one. I think it has to multi-pronged. Also, your incident data. If you've got a lot of incidents going on, where the teamwork communication is the main issue, something like that, they've got to look at for patient safety.
Okay.
I can just add that if a leadership has to be convinced about the patient safety, either the leadership needs to change itself or will be anyway changed, because the organization is not going to survive.
No.
Sir, I would like to add that it should come from the leadership.
Yeah,
It should
that's what I'm
start
saying.
from the leadership.
I am saying that what kind of a leadership
Correct.
needs convincing for patient safety, then they are not in the right place. That's all. Go ahead,
Thank you.
next question. Yeah.
And the next question is related to the interpersonal conflicts in practical situations. How do you deal with it in a team?
That's a whole lecture on itself, really, isn't it? Having those difficult conversations, those interpersonal skills, pulling people up in a safe way around their behavior. That is really difficult. I don't think I have an answer for you. I think you have to do what you can do with, compassion and kindness, but you also have to do it. That if that's risking your team or is risking your patient's safety, you have to take action. And all these interpersonal things around culture and teamwork is around the human aspect again, that third wave where we're talking about that people part of our work, and that's where it's sometimes the most complex.
I just would like to add, interpersonal conflict should not come in our way of safety. That's the number one.
Absolutely, that's right. Yeah, you nip it in the bud. Yeah.
Yes. Thank you, Bernadette, for that. And there's one more question on how do you ensure high reliability organizations?
Well, you build a culture of safety. And again, and I suppose it's all those sorts of things. It's around looking at people are obsessed with incidents and improving and making sure everyone is safe. So it's again, that thing around psychological safety, a culture of safety, good communication, clear roles and responsibilities. People's well-being is considered. Leadership is around, is everywhere, compassionate leadership, etc. That will guarantee it. And that's where those high reliability organizations come from. And they learn from their mistake and they always want to improve.
Okay. Thank you. And the last question is, do you have any specific tools for safety culture in primary care? I don't know, we use the AHRQ tools and other things.
Yeah,
So
I think you can, there are absolutely lots of safety culture tools. So I think the safety attitudes questionnaire, it can be used for that as well. But I think there's the MapSav. So, and there's other ones. There's, you can just do a bit of a Google search. Most of them, as I say, are very good tools and they all are pretty well validated. It's about the context that you use the tool in and what you do with the data afterwards.
Yeah, thank you, Ms. Bernadette. It's been a wonderful, fantastic webinar. I think it's raised so many queries as it is a very practical talk. I hand over to Dr. Vijay Agarwal to say the closing remarks.
Thank you.
Oh, thank you. I think we have been doing the closing remark simultaneously. I'm sure that it will sensitize each one of us to work more onto the team culture. You see, probably as part of our training in the medical curriculum and nursing, we are all into individual brilliance and excellence. We have to now convert it into how do we bring an issue of working as a team is, I think, at the root of solutions that the healthcare is today striving for. And we at CAHO, I think we have shown the way of how do we work as a team. So it's an excellent, I would say, excellent work to work on, to say that how do we improve the team culture in our organizations. So if you can write to us back as to how have you improved, or what help do you want from the organization to help you develop the team culture, we can be again in touch with Ms. King and with all our leaders to do another brainstorming with you to see that how do we develop the culture of safety. But let us just look at, and I think another important thing that Ms. King has brought out is the issue of incivility. I think a civil behavior, a compassionate behavior, and is again very much needed. Leadership does not mean shouting. Leadership means looking at a problem in a very balanced way and taking a fair approach. So with this, we would like to present a token of our appreciation, Anu, the certificate of appreciation to
Yes.
Bernadette King. So thank you very much, ma'am. It will be, of course, sent to you. And it's so
Fantastic.
kind of you that you could spend that time with us to sensitize this entire people from more than 20 countries are listening, have been listening to you, and I'm
Oh,
sure
wow.
we'll all benefit from it. Thank you so much.
Lovely. Look, and thank you very much for giving me the opportunity to speak with
Yeah.
you this evening.
Thank you, everyone. Thank you.
And thank you all so much for joining, and Happy New Year, Happy Christmas. Have a safe New Year.
So thank you, everyone. Yes.